the hip part 2. In this section we'll talk about arthrology, arthrokinematics, the long axis arthrokinematics, what happens if we go into a short axis scenario. We'll touch on our femur on acetabulum and then acetabulum on femur, how that changes the words, the way in which we describe things, and what that really looks like. So let's dive right in. Let's just briefly go back. Our acetabulum is concave. It is covered with articular cartilage, and it has that hyaline cartilage in there in that horseshoe shaped. And our femoral head is also covered with articular cartilage. And really just key to understand, 70% of that femur is congruent with the acetabulum. So, and then that ball and socket. So we can think about that. There's a lot of motion that are occurring. And if you guys just stand up, and we talked about that the head moves about 600 times every hour. And so if that is happening, we are really getting movement at our hips, because those are a strong base for our head, neck, and trunk. Head, arms, and trunk. So it's getting a lot of movement, whether it's big global movements like walking, or if they're just smaller stability type of movements, so keeping our head in that righted position. Okay, our open kinetic chain. So if we're talking about our open kinetic chain, our femoral head is convex and it's moving on that concave acetabulum. We'll dive more into that closed kinetic chain, where now the femur is fixed and our concave acetabulum is moving over the convex femoral head. So if we just go back to our convex on concave, we're going to see opposite motions occur, correct? So let's just go to the next slide and start to talk about what happens as we go through flexion and extension. And what we're going to see is that there's really true spin is occurring at this, and a very little other movement. And so if we're moving from neutral, we're going to see really pure spin of that femoral head around the coronal axis through the head and neck of the femur. As we go into flexion, so moving our knee up with a long axis, the head is going to spin posteriorly. So flexion, posterior, because we know it's moving opposite, right? Open kinetic chain. Into extension, it's going to move anterior. So that femoral head is going to move anteriorly. When we combine these movements with other movements of abduction and adduction, that's when we'll start to get that combination of spinning and gliding that must occur to keep the acetabulum in the correct spot. So let's just dive in. If we go through abduction, so if you guys are going through abduction, we're going to see that we're going to see an inferior glide. So right here, inferior glide of that femoral head. If we see adduction, so adduction, we're going to see that we're going to get a superior glide of that femoral head. Okay, long axis, superior glide. If we're going through medial and lateral rotation, medial rotation, we're going to see an anterior glide, with medial rotation or internal rotation, we're going to see a posterior glide, or with external rotation, we're going to see an anterior glide. So those are important for us to know, but if we have long axis and we want to improve that, those are some mobilizations that we might do, right? So we're going to understand that if we want to improve our hip range of motion, that we're going to choose our associated glides to go along with that. So when we're treating our patients, we can use a posterior glide of the hip to improve flexion and also internal rotation. And for our anterior glide, we can use that to help extension and external rotation. Now things change when we move into 90 degrees at the hip. And when we move into 90 degrees at the hip, we're changing the way in which our congruencies are and our forces act on one another. So we're going to save this conversation for in lab so that way we can all come together and just really focus on that. So I don't want you guys to worry about that right now, but we're going to just start to process through that. That hip is going to change when we move into a 90 degree. So everything we talked about right here was at a 0 degree angle. Oh, I don't know how to get rid of me. Okay. Let's see. I think we're done. There we go. Okay, so let's talk a little bit when we guys are talking about, let's go through our hip flexion. So if our hip flexion, are we bending our knee or are we straightening our knee? So I want you to think about what is going to limit hip flexion. And can we start to apply the application of insufficiency? So if I'm moving in an open kinetic chain environment and my hamstrings are limiting my hip flexion, is that active insufficiency or passive insufficiency? What happens in regard to the rectus femoris? Remember the rectus femoris, it flexes the hip and it extends the knee. So do I have active insufficiency? What happens if you flex your hip with your knee bent versus flexing your hip with your knee straight? Which one is active or passive insufficiency, and what might we do about that? So just start to problem solve that, and let's talk about that a little bit more when we're together. Okay, let's move into talking about the pelvis on the femur. Like to think about Elvis in this regard. There actually is an exercise that used to be called Elvis legs, and it's really working on getting that hip abduction, adduction moment to occur. What we're going to discuss is that the pelvis is quote-unquote moving over a fixed femur. And then a little bit later we're going to talk about those combined movements and what that looks like. This is large in part what we might see when a person is standing. And what we start to appreciate as far as differences goes in the innominate positions and also the compensatory positions that we're going to see in the lumbar spine and in the knees. It's also a common language that we'll hear quite a bit about, and so we just want to make sure that we all come together and understand that. So let's talk about anterior and posterior pelvic tilt. It's important to be on the same page. So for this discussion, we are not talking about the SIJ joint. We are talking about the whole pelvis moving as a ring as it moves through motion, okay? So with the anterior and posterior pelvic tilt, we're going to talk about the pelvic ring. So if you guys put your hands on your hips, that is the pelvic ring. It forms that ring. We have two rings in our body, the diaphragmatic ring and the pelvic ring. So as we look at anterior and posterior pelvic tilt, that's movement occurring in the sagittal plane around which axis? Yep, if you said coronal, you're right, or typed coronal. So we're looking at that move through that. So in normal movement, we see that the ASIS is in a nice even plane where the ASIS and the PSIS are aligned. With posterior pelvic tilting, we're going to see that the ASIS and the PSIS are not optimally aligned and that the ASIS is diving backwards. So if you guys all do a posterior pelvic tilt, you're tucking your belly button in and you're going to find that your sacrum is tucking underneath of you. With your anterior pelvic tilt, if you put your hands in that C position, so if you put your thumbs facing backwards and your fingers on your ASIS and you bring them forward, that is anterior tilting or anterior pelvic tilt. Okay, so let's do that again together. So if we have our hands on our hips and we go through anterior pelvic tilt, we're actually getting hip flexion at the same time. If we go backwards, now we're getting hip extension. So if someone is standing in that posterior pelvic tilt position, they're actually standing in hip extension, and we like to say that they're oftentimes riding on their Y ligament. They're just hanging on that ligament. See this a lot in some adolescent girls, and we want to just help that posture so that those ligaments are not getting so dehydrated and fibrotic and bound down, and now we're starting to lose some mobility. The anterior pelvic tilt is now, if we think about where origin and insertion is, that strong hip flexor, the iliopsoas is now being shortened and it's on tension, and it's now pulling that lumbar spine into more of a lordotic curve. We're getting hip flexion via that anterior pelvic tilt, moving those ASISs more forward. If we think about that anterior pelvic tilt, that the inferior part of that sacrum is actually being moved farther away from the sacrum, right? So now we're seeing that the sacrum is getting moved farther away from the femur. And then opposite. So if we look at the posterior pelvic tilt, the sacrum is actually coming closer to the femur. So it's really, we want to gain understanding of this as we go through that lumbopelvic rhythm, especially with being able to reach up overhead, reaching down below, what's happening at the pelvis in relationship to that. Okay, so let's talk about lateral pelvic tilt. Lateral pelvic tilt is now occurring not in the sagittal plane, right? It's occurring in the frontal plane around the anterior posterior, or that Z axis. So again, best is to stand up, put your hands on your hips, and if we start to, we can call this hip hiking and hip dropping, but it's in relationship to when one leg is going into more of an open kinetic chain environment. Some of us did this to take a look at what's happening with the pelvic motion, what's happening with the stability at that. And so what should happen is as we stand, we should start to see nice even innominance. But what can happen is you might see a patient that will hike up. You'll see this in gait, is a hip hiking in gait. So if we stand on our left leg and that right innominate comes up a lot, and we tuck that left hip into us, that is considered a right hip hike. Now, if you let that left hip drop out and that right pelvis drops down, that's called a pelvic drop. What we'll see is if this becomes pathological, is what's called a Trendelenburg gait, and it's when that hip drops out and starts to not have that stability or that neuromuscular control from, what do you think? What muscle is helping to stabilize the hip, especially in weight bearing? So it would be a lot of our glute med and some of our glute medius and glute minimus are there to really help provide stability. If we stay out into that pelvic drop, we're putting a lot of tension onto that TFL, and then that IT band starts to become really tight because it has to provide that extra stability. Remember, this is really as we go through our normal single leg stance as we're walking. So you might see that, but we also might see that shift. Now, what we just talked about open kinetic chain, but if we talk about a closed kinetic chain, we can have a lateral shift that occurs there. But you can't hip hike because you have to maintain your feet on the ground, right? So if our feet have to stay on the ground, the only thing that can happen is this hip drop. Okay, so as we go through that. One thing that's important to understand is that as we go through, and maybe let's go back to the other slide because I think it's important for us to recognize that and see the relationship of what's happening with hip abduction and hip adduction. So with our right hip hiking, what we're going to see is that, are we going into hip abduction or hip adduction? So is that angle getting closer together or farther away? So if we look right in through this area right here with our hip hiking, what are we seeing? We're seeing hip abduction, right? So if we see with a pelvic drop, we're seeing hip adduction. Important to remember this because our adductors, are big muscle groups, and there's a lot of controversy on what they really do and what's their position about, but their mass is more than our hip abductors. And so it provides a really big synergy role to our movement and to our mobility. And so we can understand that if we're getting more hip adduction, we're getting lengthening in through there and maybe even some activation into there. Okay, so let's move on. Oh, let's clear that. Okay. Good. So we see that with this, we have abducted femur on this right side and adducted femur on this other side, right? So, sorry, right side, left side. We see the abducted femur on the left side and then on the right side. This is bilateral stance, and so we see more movement into that frontal plane through this area. So we're going to see that shift. So we see that the pelvis does not sit in that equal plane. Okay, so let's talk about rotation. It's pretty important, and we want to understand what's happening with that rotation as we move around our axes, and as we move into that ring moving about the femur, and understanding this actually occurs in that vertical axis in bilateral stance, and that pelvic ring in single leg stance will move in the transverse plane around the vertical axis. So it shifts when we go from single leg stance to bilateral stance. Okay, guys, so let's just restate that. So we're going to talk about in a single limb scenario that pelvic ring is moving in the transverse plane around the vertical axis. So what we will see is forward rotation or anterior rotation of the pelvis as it occurs in unilateral stance when the side of that pelvis opposite to the weight-bearing hip is moving. So let's try that. Okay, so if I'm weight-bearing on the left, as I move my open kinetic chain limb forward, I'm getting forward rotation on my right side. So what's happening on your left side? You're actually getting some backwards rotation, right? But say that we're staying in that open chain environment, is now I can see that if I move my leg backwards, that I'm going to get in that open kinetic chain, I'm going to get backward rotation. Just like it would if I'm prepping to kick a ball, I'm going to get backwards rotation moving into that. Backwards rotation of the pelvis produces that lateral rotation of the supporting hip, which makes sense because we're always trying to right ourselves and we move in synergy throughout that. If we're talking about pelvic rotation in that bilateral stance, we can see that it's the same as that lateral pelvic tilt. That both feet have to bear weight, and so the axis of motion occurring is through that vertical axis through the center of that pelvis. And forward and backward rotation must be used like referencing which side are we talking about. So for example, are we talking about forward rotation on the right side and backward rotation on the left side? We just need to make sure that we always come back to naming each side, or else it becomes extremely confusing when we're talking about things. Let's talk about the lumbopelvic rhythm again. We talked about that when we talked about the spine and the lumbar spine and the thoracic spine working together. But what we're going to start to appreciate in the hip, that as we bend forward, what is happening at the hip and the pelvis? And what we'll start to see is that as we bend forward, right? So as we go through that, we're going to look and see that our hip is decreasing in the angle. So right in here, we're decreasing that angle, and we're actually going through hip flexion. And our pelvis is, or our nominants are tilting anterior, right? So if you guys go through that, you guys should reach to the floor and find that as you go through that, you are able to rotate anteriorly at your pelvis. What starts to happen though is we start to get abnormalities with that, where maybe I can't flex forward because my hamstrings are too tight. So I'm not getting that nice movement of the innominants, and so now I'm getting more shear maybe occurring at my lumbar spine. So we don't like that, and so we always want to make sure that, are we really looking at hip flexion, hip extension, and then in relationship, now do I have the neuromotor control to move my pelvis anterior as I bend forward? In a closed kinetic chain environment and an open kinetic chain environment, we see that hip, this open kinetic chain hip, is moving into abduction. But what's happening to the pelvis on this side? We start to see a hip hike on this side. So we'll see the opposite happening, that there's a drop on the contralateral side, okay? Because we know that our pelvis is going to try to right itself. And so we'll see that the hip with lifting your leg, going into abduction, pelvic hike, we're going through shortening on that same side of the lumbar, but we're going into left lumbar flexion, okay? Laying on our side, lifting that left lumbar flexion, but on the right side we're getting a lengthening through that lumbar spine, and we're getting relative pelvic drop here. And so we'll see that we're going to get recruitment of that glute med right in here to stabilize as we move over that. So lots is happening in that closed kinetic chain environment that we really want to make sure that we start to understand those combined movements are complementary to one another and necessary for good mechanics of the body. This slide is a little bit overwhelming. I will totally admit that. I just really want you guys to have a cheat sheet and something to go back to and talk yourselves through it. So let's just go through one of those together, or maybe even a couple of them. And maybe we can do our little camera and see if that will help. Hi, I'm in my mama's kitchen. So if we're standing, okay, and we go through an anterior pelvic tilt, that's really far away, so I don't know that that's really going to help you guys. But if I'm here and I go through anterior pelvic tilt, so if you guys go through anterior pelvic tilt, we know that the hip is flexing, right? So the angle is shortening. But put your hands on your spine and you'll start to see that we're getting some compensatory motions at that lumbar spine. And we start to understand that we have to right our eyes, and so we're going to get some lumbar extension that's going to occur with that anterior tilt. And then what happens is we go to that posterior pelvic tilt. We'll start to see that we're getting some flexion in that spine, and so we can start to gain information that someone's coming in with low back pain. If they're stuck in that anterior pelvic tilt, maybe they're just really having a hard time with the tightness of their iliopsoas, and now they're just really putting those vertebrae in the back in a bad position, and those nerves as they come out of that position in a bad position as well. If we talk about that lateral drop or that hip drop, and that what's happening, are we getting flexion? On which side are we getting flexion? So if you guys just go to that single leg stance and you drop that hip out, you're gonna see that it's oftentimes that kind of same side lateral flexion, right? So hip drop and you're gonna get that same side lateral flexion, and hopefully, because we can't, if we're here and you try to laterally flex the opposite side, you're going to fall over. So go through each of these and just come ready during lab for us to have a good discussion and watch people move in a lot of these different ways. Okay. We're just going to briefly touch on the amazing kinetics, right? So single leg stance, And what's happening with taking on the forces of the head, arms, and trunk. And in single leg stance, our body is taking 3 times the amount of body weight. You would think, okay, well, I'm taking the whole body weight, yes, but then you also have to take into account that weight of the limb that is in that open kinetic chain environment. And so that's now adding into the forces that are being taken through the weight-bearing joint. And then what do we see with walking? Well, with walking, now we're getting ground reaction forces, and so we see that we're taking 5 times the forces through that area with walking. And then what happens with running? Well, with running, we're seeing that there's 10 times the amount of forces going through that area. And pretty remarkable that running actually is one of the best things, and we're supposed to run. We're made to run, right? We're made to run away from lions and tigers and bears and things that were going to get us. But it's really good to, in this day and age, use running as a tool to open up that anterior body wall and stretch out those hip flexors, stretch out those pecs, and get everything moving that way. So just a brief understanding of that, and we'll keep that discussion as we move into posture and gait. You know, the hip is a big weight-bearing joint, and it's got these trabecular systems that are built to take all of this. And that medial trabecular system is that upper part of that femoral shaft, and it's got that accessory system, the medial aspect of the femoral shaft, and it fans out into that greater trochanter. And then the lateral one is that lateral cortex, and it responds to all the forces with the contraction of the abductors, and it has a tendency of really that head and the neck to bend with weight as weight bearing is accommodated. And so we start to see that they're within the trabecular system, so the medial, lateral, and then we have that specific zone of weakness. And why do we care about this? Well, that zone of weakness is where we start to see that we might have some increased fractures in this area, and that it's right really in between. So we see the medial is at that femoral head, and then the lateral system collides with that, right? Provides that tension into the system. And then we have that small trochanter system out by our greater trochanter. But that zone of weakness is right at that angle of where the neck comes into play. So if we just kind of draw a little picture, if hopefully my little guy is going to work. If we have our neck right this way, okay, and this is where our medial trabeculae is, and then our lateral comes into that, right? It's right where that angle of inclination is where that zone really of weakness is. And the trabeculae don't cross each other at that, and that's right at that femoral neck. And oftentimes in our osteoporotic patients, we'll see, we'll see that they achieve a fracture there, and they've fallen and they fractured there, or some of our theory is that actually is because it's that zone of weakness, it's actually fracturing, causing our person to fall, or our patient to fall. Let's just touch a little bit on the hip capsule and the ligaments. You guys will get this a lot more. Should be anatomy review, but our capsule has really major contributions into stability, and it's there to help provide stability. It's really thick anterior and superiorly, which makes sense because we talked about that natural anteversion that we have, and it's thin posterior and inferiorly, which allows a lot more movement into hip flexion, so it doesn't really contribute to that extension check. The femoral neck is intracapsular, so just important to know that. And then the greater and lesser trochanters lie exterior to the capsule. The Y ligament of Bigelow, is extremely important to understand and to identify those different layers, because it's a really, blue's not a great color. Let's change that. So that Y ligament, or that iliofemoral ligament, really important in the stability of the hip and plays those different roles and the different orientations. So I want you guys to understand it's the strongest ligament of the hip, and you can palpate it on yourselves. It's an area where we can get bound down. If it gets too tight, it will maybe cause some, what we would call it, snapping hip syndrome. It's extremely taut in extension. So, we don't have a significant amount of extension, but understanding if you might need to do some manual therapy in that position of tautness to get some release or some change out of that area. The superior fibers are what help us check adduction or adduction. And then those inferior fibers help us check abduction. Makes sense how they're orientated, so it's not something that you necessarily need to just memorize straight away, but just remember, if you can visualize the orientation of those fibers, it really is going to help you with the role of what they are for. Our pubofemoral ligament, I really want you guys just to, the origin, that anterior pubic ramus. The insertion is that anterior introchanteric fossa. I want you to just understand, if it's taut in hip abduction and extension, that's what it's, there to check. So just know that the role of those, and so if we're getting some instability, we might get some instability into abduction and extension if that pubofemoral ligament is compromised. And then our ischiofemoral ligament, those spiral fibers taut during extension and loose during flexion. So opposite of that, that joint capsule, right? So joint capsule pretty loose in extension, but taut in flexion. Okay, so just understand the position of stability for the hip is full extension. And then vulnerability is that flexion and adduction. So that sitting with their thighs across. We already talked about the ligamentum teres, so you guys will just know that and understand that does play an important role. Okay. It's interesting to note that our ligaments don't resist flexion. They're all loose in flexion, and extension really does have a lot of stability, which makes sense if we're standing in that slight, if we're standing in neutral or slight hyperextension of the hip, that we need that strong check to make sure that we're not dislocating anteriorly. Okay. Extension winds up the ligaments and flexion unwinds them. So if we're trying to maybe do a joint mobilization, we might choose to do things more in flexion. If we're doing some soft tissue where we want to melt some of those tissues, we might go into external or extension. And then internal rotation, those posterior ligaments get taut, and then external rotation, anterior ligaments get taut. That makes sense. You guys should just go through that yourselves and double check. So just kind of those key reminders for you. We do have bursa in our hip, and that bursa really there to provide some space within that tight hip area, especially with all the ligaments and those overlapping muscles that come into there. What we'll see most common though with hip, if that bursa really is the cause, is we might see some of the issues in the bursa in through here. So that would be under our iliopsoas. And if that iliopsoas is becoming so tight and is compressing on that bursa, we might have some just negative effects where that bursa is getting mad. What we'll also see is as the iliopsoas comes through there, if we're sitting just a little bit maybe into that posterior pelvic tilt, is the iliopsoas will snap over, and it might start to irritate the bursa at the same time. We'll hear a lot with hip pathology, though, that we're going to get trochanteric bursitis. So as the TFL crosses and lies across that, we're going to get some bursitis into that area, especially if we have what type of tilt in our pelvis. What do you guys think? With a hip hike or a hip drop? Would we start to get maybe some increased hip bursitis? Yeah, so probably with a hip drop, because it's going to place more pressure out onto those areas. Hip joint musculature, I'm not going to dive deep into this because I think that there's no need for you to hear it twice in a recorded lecture and in your anatomy. But I want us to just understand that there are certain principles that are accepted in the hip, and these are important when we just think about the kinematics and what's happening with our patients. Understanding that the first principle is that optimal range of our hip musculature is in that mid-range, or it's slightly flexed. So we want you guys to think about where do we gain the most loss at with our current state. So a lot of our patients are going to have loss of stability. So they're going to move more in the frontal plane with their hips than they should. And that should bring us to think about that hip abductor, and if it's working to provide proximal stabilization. And if it is, great. And if it isn't, are we working it in the right way? So are we doing a lot of open kinetic chain, where we're going through lots of full range exercises, or are we working in a closed kinetic chain environment? So start to piece some of that together, and you guys are doing so great that I think you're all on that page right now, so that's awesome. Okay, then we're going to talk about the two joint muscles and force. So our two joint muscles, we have a significant amount of them in the hip. So as you guys go through and review your anatomy and get ready for our lab, think about, okay, the rectus it crosses two joints, it's in charge of two actions, so what does it do? Hamstrings, what does that do? And start to go through each ranges of motion, so our flexion, extension, abduction, adduction, that kind of thing, and understand that those two joint muscles, they generate the most force when they don't have to shorten over two joints. So if they're having to do both of their roles at the same time, we're going to lose some force generation from those. Okay. The optimal tension is achieved really through eccentric exercise. So why do we want tension into our muscular system? I'll tell you, one of the main reasons is because without that tension, we now get increased congruency into the joint. So that's not something that we want, right? So if I have decreased tension, and we have, remember, our convex femur and our concave right acetabulum, okay, if I have decreased musculature, this space right here is getting decreased. And if it's getting decreased, we start to wear away the articular cartilage, and now what starts to happen is we get bone-on-bone contact. If we get bone-on-bone contact, we start into an arthritic type of situation. And we start to have increased instability. So we might have bone-on-bone, then we have wearing away of the labrum, and now we have maybe some slight dislocations or giving ways, and that's just not really that great and functional for our patients, and we really want to make sure we are on the forefront of that. And then what we start to see is inversions of muscles within the hip joint, meaning that when I go through and I think about my piriformis, and I'm standing at 0 degrees of hip flexion, if I have 0 degrees, my piriformis acts as a lateral rotator. But now if I flex my hip and I'm at 90 degrees, now my piriformis shifts and it's now a medial rotator. So many of our hip muscles act like that. And so we just want a gross understanding of what is it like to go through walking, and then what do we do when we move that hip into 90 degrees, which is where we'll do a lot of our manual, and what's the effect when we do that. So I really just want you guys to touch on, when you're reviewing through your chapter and you're reviewing for your anatomy, is take a look at hip flexion, understand, those 9 muscles that cross over into that area, and what is that really acting on, and how does that influence our position as a physical therapist. And start to apply, okay, hip flexion, what do I need that for? I want you guys to think about, well, we need that for sport, we need that for activity in our open kinetic chain environment, but what's happening to your hip flexors in a closed chain environment as we move through gait and many of our upright motions that we're going through? Our adductor groups, they're are great synergists and they're stabilizers. And a lot of patients, if we have a change in our angle of torsion, and if we have more internal rotation, what are we doing to those adductors? And we start to see with pathology such as CP that, man, do we get really tight hip adductors. Even points of stability come from that adductor group. We hold a lot of tension there. So if you're stressed, or if you're scared, or if you're depressed, we go into a closed down posture, right? So you guys, if you think about what happens when you're feeling that way, now we're getting tightness into that. And then our abductors, man, those great stabilizers of the hip, they're the best friend to our knees, so we really want to think about that. Hip flexion, or hip extensors, so the big back butt, man, that butt is your best friend, and a lot of us have forgotten how to use it because we sit so much. And so when we're retraining our patients that have gone through surgeries, or maybe even that have been hospitalized for a prolonged period of time, and we're working in an acute care setting or acute rehab, man, do we want those big back muscles to work? That the glute max needs to come to play. And then start to think about the role of the rotators. Man, they have a lot of stability, right? They provide a lot of stability. But in a lot of our activities of life, we need a lot of rotation and we need a lot of synergistic movement. So I want you guys to go through and review that. Okay, lastly, let's just touch on a little bit of hip pathology. We've talked about what happens with there's itises in that. So osteoarthritis, start to see joint changes. Decrease in strength lends to decreased stability of that joint. We're riding on our ligaments more. We see a lot of weight gain as we go into aging, and all of this starts to provide more of that stress into that area. We see a decrease in function due to abnormal increase of that magnitude of forces, and it starts to weaken that bone. So it's kind of a cascade. We start with osteoarthritis, but what will often happen is that we'll end up with a femoral neck fracture. Might be combined with that coxa-valga, and as we start to see that predisposes that hip to decrease in stability, but really just understanding that all of these start to come to play, and OA will often lead to a fracture, and fracture, especially in the elderly, if they're fractured, if they receive a fracture or hospitalization, that really decreases their likelihood of survival. And it's just one of those populations that we can really truly affect with our ability to strength train and get them much more mobile and functioning. We talked about coxa-vara quite a bit, right? So understanding that, I just want you to understand the two between coxa-valga and coxa-vara. And then, just briefly talking about with our Y ligament, that is pretty awesome and how much stability it has. And it can actually help someone who is a paraplegic, who has spinal cord injury, stand up, and they can actually ride on that ligament, and that ligament is so strong that it can support that. We'll talk a little bit in lab together about femoral acetabular impingement, and we'll talk about a little bit more, touch on the snapping hip syndrome, see if any of us have that, and just keep on applying these principles to yourself. Watch your roommate move. Watch your spouse or your friend Go to the store, start watching people move and see some of the abnormalities that are starting to happen, and guys, just start to have fun with it. So, okay, great job. We will see you in lab.